my name is Adrian. I'm one of the interns at Cottage, and as an intern, we spend quite a bit of time thinking about electrolytes, checking them, and repleting them. It's a constant thing that we do. And so usually, especially in the case of potassium, but on the other hand, when it kind of swings in the other direction, patients come in and their potassium is quite high. One of the treatments that we use, Kayexalate, is the myth that I'm hoping to bust today, and that specifically that it's a safe and effective agent in the treatment of acute hyperkalemia. So my overview is basically a little bit of background. Why do we worry so much about hyperkalemia? And what is Kayexalate? What about the development? Review the data of the safety and efficacy, and talk briefly about some of the new agents on the horizon that might be promising to replace the use of Kayexalate altogether. So hyperkalemia is a really pretty common problem. It can occur in up to 10% of hospitalized patients, and it's an independent predictor of increased mortality. It's associated with higher healthcare costs and prolonged stays. So UpToDate is defining this hyperkalemic emergency as kind of three ways. Clinical manifestations of hyperkalemia, which we'll talk about, when it's greater than 6.5, and then in this other range of 5.5 to 6.5 in patients with CKD, and some sort of reason for ongoing absorption of potassium. So is there a crush injury, is there rhabdo, or is there something like tumor lysis? And so what are these clinical manifestations that we're talking about? So one is muscle weakness, and sometimes this can manifest similarly to GBS with some ascending weakness. You can have flaccid paralysis, you can have depressed deep tendon reflexes, but more concerning are the cardiac manifestations. So when the potassium is too high, it can actually bring the resting threshold of the cardiac membrane closer to the threshold that you need to generate an action potential. So this kind of increased excitatory state can induce some really dangerous changes and dysrhythmias and conduction abnormalities. And sometimes this is reflected in the EKG, like it's showing here. The lower ranges, sometimes you can get peaked T waves, and as it kind of starts to increase, you might see the loss of the P waves. The QRS starts to kind of stretch out a little bit, and things like that. So what are clinicians doing about it? This is a study published in 2018 that looked at 14 different emergency departments and basically 203 patients with hyperkalemia and what the physicians did. So they documented the types of therapies and how they are combined to treat the patients, and they found that 7 different therapies were used in 43 different varying combinations. So really there's not an accepted standard of care protocol established, and the practice patterns vary quite a bit. So what are these interventions that they talk about? I like to kind of approach it in 3 pillars. So first would be, most importantly, to stabilize the cardiac membranes with calcium. And then we think about shifting the potassium either inside the cells or trying to eliminate it from the body completely. So shifting with a combination of insulin and glucose, beta-2 agonism, or sodium bicarb, and then eliminating with dialysis, if it's available, loop or thiazide diuresis, or the GI cation exchanges. And so, like Kayexalate. And UpToDate is recommending that we at least consider an oral potassium binder in these situations that we discussed. So now I'll talk a little bit about the history and background of Kayexalate, which is sodium polystyrene sulfonate, which I'll be referring to as SPS going forward. It's an insoluble polymer cation exchange resin that binds sodium for potassium in the intestinal cells. So once it's bound to the resin, it's eliminated in the stool. And so this comes in this powder or it comes as an enema. And it's kind of described as the onset of action from 2 to 24 hours. And initially it was suspended in water, but due to concern of constipation or some bowel impaction, it was later combined with an osmotic laxative, sorbitol. And it was felt that maybe the sorbitol could actually increase the amount that is bound to the resin of potassium and increase its effectiveness. First synthesized in 1935, but then in 1953, The Lancet published an article of just 5 patients who were anuric, and they were treated with the SPS, but over 5 days, and they demonstrated that the potassium went down after that treatment. But there was no control group, no statistical analysis. And then a couple years later, in 1958, FDA approved it for the use of hyperkalemia. And I think it's important to note that this was approved before the Kefauver-Harris drug amendment of 1962 that came around in the time of thalidomide, and pregnant women were taking for nausea and vomiting that led to birth defects. And so after that event, these laws were put in place, requiring more drug safety and efficacy data prior to FDA approval. So let's go on to the efficacy information. And I'm defining efficacy as after a single dose, is there a statistically significant decrease in the potassium, just any at all. So this first study in 1998 looked at 6 patients, and they gave 4 different types of resins and placebo, about 1 week apart each, and they measured the potassium before and then 4, 8, and 12 hours after. And as you can see from the graphs here, most of the lines are flat, and some of them even go up. So there was none of the regimens reduced the potassium. But that was just 6 patients, so what else do we have? So this study, a retrospective study in 2016, they looked at 501 inpatients who received SPS regardless of the renal function. And they found that average potassium reduction at the first check after the first dose was 0.93, but they also included patients who received other treatments for hyperkalemia. So it's hard to know what can we make of this information, specifically about SPS. And then this study in 2015, a double-blind randomized controlled trial, looked at SPS daily for 7 days, compared it to placebo, and it did show that there was a superior reduction to placebo of about 1 at the end of the week, but there were still quite a bit of patients who remained hyperkalemic, and this is really applicable as much to when we're thinking about acute hyperkalemia. So then this next study in 2016, this looked at what about the dose of the SPS and the formulation. So as you can see, it seems like 15, 30, and 60 grams, there seems to be a dose-dependent increase in the reduction that's obtained, but there's still a good portion of the patients that remain hyperkalemic afterwards, and they didn't include any statistical analysis of the reduction on the left here. And I think also significant is all of the patients receiving the enema remained hyperkalemic. What about patients with specifically advanced CKD? So this is often patients who we see in here in the hospital who have complications of hyperkalemia. So in 2018, this was a retrospective cohort study, and they looked at the single dose, excluded the other treatments of hyperkalemia, and did find that there was a decrease of about 0.8 for the 30-gram dose, and this was statistically significant. But in this patient population on RRT already, it's kind of a population where we would have a low threshold to just send to dialysis anyway. And so the clinical utility of this isn't as helpful. The other thing that they kind of tracked in this was the GI side effects. And this brings us to our next kind of category of our evaluation of the myth in the safety. And so they did find that 5% of their patients had a GI side effect, 5 with ulceration, 1 with rectal hemorrhage, and 2 of the 6 they thought was possibly caused by the SPS treatment. So for safety, SPS is associated with increased bowel ischemia, and it's about a 0.27 to 1.8% incidence. And the mechanism isn't entirely known, but what we're going to review now is attempts to kind of tease that out and really see, is this a significant risk? And if there are any patient populations that are particularly susceptible. So in 1987, this group looked at 5 cases of patients with uremia treated with SPS enemas, and they all went on to develop extensive ischemic necrosis with SPS crystals noted in the lumenon pathology. 4 of 5 of them died, so this was a pretty significant complication of the treatment of uremia for these patients. And then they went on to look at a group of rats. They took one group of rats, gave them nephrectomies to induce the uremia. The other group of rats had a sham operation. They gave all the rats different types of enemas, saline, SPS alone, sorbitol alone, or SPS in sorbitol. And importantly, I think that all of the uremic rats had some necrosis. And then a majority of even the non-uremic rats went on to have necrosis. But also there was no intestinal injury with just SPS alone. So this kind of makes us think, could this be the sorbitol? So this was a systematic review in 2013, looked at 58 cases of the SPS bowel-related GI adverse effects, and 17 cases actually happened without sorbitol. And there was a 33% mortality. And it seems like also 91% of the cases had patients with either an AKI or chronic kidney disease, including those that are advanced. So it seems like it's still happening even without the sorbitol. So then here, this was an interesting study in 2013 that looked at the pathology records of all of the colon specimens where they verified intestinal necrosis containing the SPS crystals. This was from 1998 to 2007 in the Rhode Island hospital. And they wanted to see, who are these patients? Is there any trend? Who is most at risk? So they were able to confirm 11 cases of necrosis with a temporal association, relationship with the oral SPS administration. And how did this present? So most of the common symptoms were abdominal pain, and then distension, and then some bleeding as well. And it seems to most often occur in the colon, and it can occur anywhere from 3 hours to 11 days later. And in terms of the patient characteristics, some of them were actually hospitalized just for a non-critical illness. So they came in, were given this treatment, and then developed this really severe complication from it. And some had normal renal function, some had very advanced kidney disease as well. So it seems to me that really everyone could potentially be susceptible to this. And then this study in Sweden was a retrospective cohort study taking patients who were hooked in with a nephrology clinic, never previously received SPS, and wanted to know, did this increase their risk of hospitalization or death attributed to a severe adverse GI event after having taken the SPS. So of the 19,000 patients, 3,690 received the SPS. 59% continued it chronically, and there were 202 severe and 149 minor GI event records that were recorded afterwards. And they found that this initiation was associated with a higher incidence of severe GI adverse effects with a hazard ratio of 1.25. So with all of this, and like what Dr. Fried kind of already alluded to, the FDA in 2009 issued a warning recommending against the use of SPS and concomitant sorbitol due to these adverse events reported. And then in 2016, further advised against the use of SPS in patients with these kind of characteristics: abnormal bowel function, patients at risk of developing constipation or impaction, and patients who develop constipation afterwards. So what about cottage hospital? This is basically inpatient oral SPS prescription since 2016, when we have the data. And it shows pretty variable trend, but still, even last year there were over 200 prescriptions, and again this year there's already over 200 prescriptions. So this is an important thing to be aware of. And as a cultural competency highlight, I found this statistic that was pretty startling to me, that racial and ethnic minorities are 1.5 to nearly 4 times more likely than their non-Hispanic white counterparts to require renal replacement therapy, with African Americans suffering from the highest rates of ESRD. So I think it's an important reminder to think about the social determinants of health that are affecting our patients and what we can do to work with them to address that, both individually and through policy change. I'll just briefly touch on 2 of the newer agents, both FDA approved in the last 5 to 10 years, patiromer and this Lokelma at the bottom. So they're both binders as well. They're exchanging the potassium in one in the colon and one in the small bowel, and they both have a much more favorable safety profile, as well as shown to have efficacy both in the acute treatment of hyperkalemia, as well as potentially longer term as a chronic outpatient medicine we can offer to our patients. And so coming up will be the results of this study, the K-binder. And this is kind of a head-to-head comparison of these different types of oral binders. So that'll be interesting to see, and they're measuring kind of similar potassium levels before and after during the hospital stay. So to kind of conclude, studies that are claiming the efficacy included other treatments of potassium lowering agents, or were conducted over a longer period of days, like the 7-day trial that we talked about. There's still a lack of high-quality evidence demonstrating the efficacy in acute hyperkalemia, and this bowel ischemia is really an under-recognized risk with significant associated morbidity and mortality. So it's really something that can occur with or without the SPS or the sorbitol component. And even basically all patients seem to be potentially susceptible to this effect. And now that there are more alternate, potentially safer, even more effective agents, I think we should kind of reconsider our prescription of the Kayexalate and go with some of these newer agents or others that are better for our patients. And that's it. These are my resources.
That's great. Stay up here. Anybody have any Anybody have any questions, comments?
I was just asking if anyone knew if we had serum formulary or not.
I know I've seen the Localma prescribed in the hospital.
I was just curious.
Yeah.
All right, well, I guess it's time to vote then. There's no further discussion or questions, comments. So what we're going to vote on is whether is this a myth, is Kayexalate a safe and effective agent for the treatment of acute hyperkalemia. Again, though, we're really focusing on acute treatment, acute hyperkalemia, not chronic patients here. So how many people think that this is a true statement, that it is safe and effective, we should just continue using it? How many feel that it's plausible? How many feel that this is probably not very effective and not safe? It looks pretty unanimous. All right. All right, we're busted.